Hi, I'm Jackie Cohen Roth, CEO, founder of Cannabis MD. Welcome to another Cannabis MD video profile. These are conversations that I've been having actually since the start and impact of COVID on our opportunities to get together in the industry and share information, and with a focus on ensuring best practices in the industry, which all focuses, as far as I'm concerned, on ensuring quality patient care for medical cannabis patients. I'm delighted today to have Dr. Patricia Frye join me. Dr. Frye will be part of a roundtable discussion January 7th, 2021 with Dr. Ethan Russo and Dr. Bonnie Goldstein, during which we're going to be focusing on neurologic disorders and the clinical application of treating these diseases and disorders with medical cannabis and the research behind the opportunities of the to incorporate the adjunct therapies. So welcome, Dr. Frye.
Thank you. Thanks for inviting me. Pleasure to be here.
Thank you. Dr. Frye, I met you, or actually I heard you speak and met you the day, this was early on, in the founding or the launch of Maryland's medical cannabis program. You were presenting at a law firm. And I was so impressed by what you had to say, where you really did a phenomenal job of sharing an introduction to cannabis science. And you explained at that time to those folks that were part of that meeting of where the difference in the states of physicians not being able to prescribe medical cannabis, but rather that they recommend medical cannabis. And you were very emphatic about that you do go as far as recommending particular strains and going into what patients should be looking for when they go into a dispensary, and so how best to treat your patients. And I was just so impressed by that. And I searched you out as my personal first recommending physician in Maryland. So we have a history.
Well, thank you. I'm glad. I'm glad that all worked out. Mm-hmm.
Yeah, and as wanted to share, Dr. Frye, I'll have you speak to your experience in the industry as well, and how you got started in the industry and what your attraction, which led you to become a cannabis physician. But Dr. Frye authored the Medical Marijuana Guide, Cannabis and Your Health, and clearly I use this book quite a bit and have referenced it during my graduate school studies. And it's a phenomenal resource. So Dr. Frye, if you would share personally what brought you to the industry, your clinical training and background.
Well, my training is actually in pediatrics and in anesthesiology. And I was actually somewhat kind of retired when I came back from California, back to the East Coast, and I kind of piddled around for a while, and then I said, well, maybe I'll use my California license and I can find a nice little telemedicine job. I was thinking it would be something more like urgent care. And the recruiter called and said, well, we have this job for you. It's out of San Francisco. You can work from your home on the East Coast, and it's doing medical marijuana evaluations. And I said, I don't know anything about marijuana, but everything else was just right. So I said, well, I decided to interview with the company, and I felt comfortable. And even though I didn't really know much about the plant, they made it sound like, well, you probably don't have to know all that much. But anyway, it was slow. I was seeing 2 or 3 patients, during a shift. So I had a lot of time to talk to patients. In between patients, I had a lot of time to read. And over the course of the year, I took a course. So I was introduced to the Society of Cannabis Clinicians, and I took their modules, which introduced me to the endocannabinoid system and to the ethnobotany of the plant and into the clinical conditions that seem to respond to cannabis and why. But I just heard these patient stories over and over, how I used to be on opioids for my low back pain, and I used to be on this for that, and now I just use a little cannabis, and I use some salve, and it helps my arthritis. And I use a tincture and I take a few puffs, and these were people from all walks of life, from very debilitated to highly functioning people, and from everywhere from 20 years old to 100 years old. And at the end of a year, I said, you know what, this is pretty amazing, and people should know about it, and they should have access to it.
Now, what year was this? If you can put a time stamp on it.
Yeah, this was 2015. So this
This
was,
was before product came into Maryland.
yes, it was
For
before product came into Maryland. I was able to do evaluations for patients in DC,
mhm.
but patients from Maryland were seeking me out because they knew it was coming. And what I did while I was waiting for the dispensaries is, depending on their condition, I would treat them with a hemp-derived um, CBD tincture or capsule. There weren't many capsules back then. It was mostly tincture and topical and salves. And if they needed a little extra THC, which wasn't much in the CBD oils, I would write a prescription for dronabinol, which is the same THC molecule that's in the plant. It's just all by itself, suspended in sesame oil. So the combination of the THC with the CBD, I really saw some pretty impressive improvement. And so then when the dispensaries opened in Maryland, I just transitioned those patients to dispensary medicine, and mostly a combination of CBD and THC, because actually most of my practices, despite the fact that I trained in pediatrics, most of my practice is over 50 for sure.
And that is the fastest growing patient demographic of
Mhm.
patients. Yeah, if you would share a little bit more about your background. So we skipped right over that. Is that recognizing the critical importance of the need for cannabis science education for physicians.
Right. I went to medical school and trained in pediatrics at University of Maryland, Baltimore. Never heard of the endocannabinoid system. I finished there. I went to Baylor College of Medicine in Houston, trained in anesthesiology. Learned a lot about pain management and putting people to sleep. Never heard of the endocannabinoid system. So it's really, and since then I've trained even in obesity medicine through Harvard. Never hear about the endocannabinoid system. It's just a modulating system that has its hand in everything, and it's completely ignored when it comes to medical education, medical training. It's completely ignored, and it's mind-boggling that you could have an important system that deals with keeping the body in homeostasis and regulates everything from pain to anxiety to sleep to appetite, and no one talks about it. It's like,
Why is that? I mean, this is the Schedule 1.
I think it's the Schedule 1. It's the fact that the cannabis has compounds in the plant that activate receptors in this system, and it's just been something that's been taboo over the years. It doesn't make any sense to not even acknowledge the endocannabinoid system, because that system can be upregulated or toned by a number of different activities and nutritionally that it doesn't even involve cannabis. But you can teach patients how to eat food that's not going to downregulate it, how to avoid toxins that downregulate it, how to get enough sleep so that it's upregulated, how to increase their omega-3s and get enjoyable exercise. There's so many other things that can help tone the endocannabinoid system that it's almost a crime that it's not addressed, even because it doesn't even have to involve cannabis. Cannabis does a remarkable job of activating these receptors and influencing the levels of the endocannabinoids that our bodies make. But there's so many other things that patients can do to help the system more efficiently and to reduce inflammation and to improve health.
Yeah, and I've heard it referred to as more conversation referring to as the endocannabinoid dome versus the system, as you're referencing, is that it incorporates so much. So perhaps that the dome is a far more enlightening word that captures just how critically important the endocannabinoid system is. But again, pulling in all these pillars of health and wellness that outside, as you're saying, food, exercise, let alone utilization of the cannabis plant. So, and you really quickly would speak to that you're an entrepreneur of sorts, where you opened up your practice, and that this is Tacoma Park Integrative Care, and this practice is specifically for cannabis practice.
Well, it kind of started out that way. It's funny that I started out as really focusing on using cannabis, and so I really looked at attracting patients who had chronic conditions that were not improving with conventional therapy or pharmaceutical therapy, and helping them explore cannabis as a means of achieving better health and just feeling better. Over the course of over the years of doing this, I learned more and more about what people do and don't do that sometimes gets them into these chronic conditions in the first place. And so the practice is morphed more into an integrative wellness practice. So that I see patients who don't use cannabis, but they want guidance with nutrition and with exercise and with mind-body techniques and sleep. And so there are a number of other things that I now do. But it's funny, I have a colleague who started out in wellness, and it kind of morphed into including cannabis, because they just go hand in hand. Whereas I started out focused on cannabis, and now it's broadened into wellness and using integrative techniques to help people get better and feel better.
All right, well, let's drill down then into some of these neurologic disorders. And so with your patient population that you referenced, that where they're mostly over 50, so specifically we're talking about most likely, I would say, then Parkinson's disease, Alzheimer's disease. Are you treating adult patients on the with ASD?
Yes, young adults. The funny thing is that most of my practice is over 50, but most of the neurological patients I see are pediatrics. So I see a lot of seizure disorders. I see a lot of autism. Partly, there's a large autistic population in Howard County because they offer a lot of services. So a lot of families with autistic children do tend to go to live in areas like Howard County. So I see a number of them. I see a number of referrals, let's say from Kennedy Krieger. So there are a lot of seizure patients. I tended to get patients from Children's Hospital. That has kind of decreased somewhat since Epidiolex was FDA approved.
Mm-hmm.
Every now and then, still some of those patients will come back if they haven't done as well with the Epidiolex. But I do see in adult patients, I do see Parkinson's. I see a lot of neuropathic pain. I see multiple sclerosis. Every now and then I'll see a Tourette's syndrome patient. I don't see too much Huntington's. And I have a fair number of patients who are paraplegic or with cerebral palsy or kind of a chronic spasticity. And I see those patients as well. So I say most of my neurological patients are actually pediatric age, but I see a number of adults with chronic neurological conditions as well. I see some Alzheimer's, not as much as I saw in California. And interestingly, in California, a lot of those patients could if they were in a assisted living situation, they could get their medicine in the facility. That's a little bit more of a challenge here on the East Coast, because a lot of those patients are not at home, and that may be why I don't see as many of them as I would like to.
Yeah, there is that. We spoke about it on the last webinar. We hosted with Cannabis MD on chronic pain, and that the assisted living facility in New York State, where they're providing access for their patients. So with the COVID is the positive impact that we've had on delivering healthcare with telemedicine. So has your patient population grown as far as your cannabis practice outside of the geographic borders?
I don't think so. I mean, I'm licensed in Maryland, DC, and Virginia, and I see a few new patients every week. But most of my practice are returning patients. I'm starting to see a small uptick in Virginia now that Virginia has 3 dispensaries that are open. And also because Virginia patients can come to the district, they have reciprocity. So I've seen a little bit of an uptick with Virginia, but I would say all in all, the patient load has been about the same. And it's a little bit hard to judge because I'm pretty much doing everything from home and by myself now. So I never did a lot, high volume. But when I was in the office, when I was actually practicing in the office where I had an assistant, I was seeing probably 4 or 5 patients a day. Now I see 3 or 4. So it's not increased, but it's definitely been a big help for a lot of these patients where mobility is an issue, transportation is an issue. For the autistic patients, it's been wonderful because any change in their routine for a lot of these kids and young adults is very upsetting. So it's safer. There were some that was where there's so much aggression when they get upset that it just wasn't safe for them to be brought to the office. So I would have to make the home visits. And so the telemedicine is really, now that Maryland and DC allow it, it's really helped a lot. It's also opened up the availability for palliative care for hospice patients. It's really difficult for a lot of those patients to come in. And now with COVID, it was just too dangerous. And this is so much better to see them virtually where they can still be in their bed and be somewhat comfortable.
All right. That's great. So let's get into some of the specifics of treating your patients. So we're talking about CBD, CBD THC ratios. You spoke about Epidiolex, Tramadol, and so essentially these are isolate products versus a product that would have a full plant spectrum, and then that leads to the incorporation and paying attention to the terpenes. And so I've had one conversation with a provider where he considered that terpenes were a hippie's marketing scheme, essentially, and that he didn't see value in terpenes in treating in his practice. When you are treating, let's pick a neurologic disorder, and pick one, please, and let's talk about what a patient profile looks like, your approach, and are you paying attention to a terpene profile in a product?
Oh, I absolutely disagree with the other provider. There's so much more to the plant than the cannabinoids. So much more than just CBD or THC or those ratios. You can have a patient, and I'll take seizure for example. I have a patient I've seen where I look at the relaxing terpenes when I'm looking at tinctures for patients with seizures or even for anxiety disorder, which I sometimes see. That's not really a neurological issue, but the seizure patient, you can have them on the same amount of CBD and switch tinctures and have breakthrough seizures. And if you look at the terpene profile, you might find that there's not as much linalool in that second one, or there may not be as much myrcene or some other terpene that tends to be relaxing. So they're even with patients who have been on whole plant CBD products and then go to Epidiolex. Well, the Epidiolex is an isolate. Well, I don't know if they have anything in there other than CBD. I think that may be an isolate.
It is an isolate. I mean, my understanding and studying it, and actually you're going to be on the panel with Dr. Russo.
Yeah, and so he's with GW. But the dosing for Epidiolex, it's like they were dosing like 20 milligrams per kilo of CBD, where with the whole plant, at least I start, about a quarter of a milligram to a half a milligram per kilo. Mm-hmm. It's a big difference in dosing. Yeah. Huge. So it just it can't be just the CBD. It can't be just the THC. Yeah. Those terpenes influence how that plant is going to affect a person. And so if you compare a whole plant CBD with relaxing terpenes like linalool, myrcene, to an isolate, you're going to need a much larger dose of the CBD with the isolate. And then the larger the dose, the more likely, the adverse effects aren't hideous. They're not anything that's permanent, but the higher the dose, the more likely you are to run into some adverse effects. Too much CBD can cause diarrhea, it can cause anxiety, it can cause daytime sedation. We don't really see that with the whole plant CBD tinctures.
And my understanding, and Epidiolex is quite expensive.
Oh, it's crazy expensive. Yeah. So unless your insurance is paying for it, and pretty much it will only pay for it if you have Dravet, Lennox-Gastaut, or now tuberous sclerosis. Mm-hmm. So if you don't have one of those three diagnoses, Epidiolex is around $1,000-something per month. It's per vial. It's 100 milligrams per ml, so it's highly concentrated. Mm-hmm. But I use a CBD oil that's I have a CBD oil that's 80 milligrams per ml. And I have others that are 50 milligrams per ml, 75 milligrams per ml. So it's not that much more concentrated. So I don't understand, why it is. Well, I understand why, but patients, unless you have that diagnosis, can't afford to spend thousands of dollars a month for a CBD.
And these are the rarest seizure disorders that we're about.
Yeah.
And per your book, my understanding, and as I've utilized your book in my graduate program, is tinctures. Our favorite delivery method, is that so?
That's probably my favorite delivery method, and I'm going to tell you why.
I was going to ask you why.
Okay. To me, tinctures if they work for a patient, they're the best of both worlds. You get oral mucosal absorption directly into the blood vessels in the mouth, which only delays the onset of action by maybe 10, 15 minutes compared to inhalation. But you don't hold it in the mouth that long. You swallow it, so it goes through the gastrointestinal tract, and then it's absorbed, goes through the liver, and all of that will extend the length of time that it's active. So you're going to give up about 10 minutes. Let's say inhalation, it takes about 10 minutes to start working. Well, that's good because your plasma level goes up like that, but then it goes right back down. It's only going to be effective for 2 or 3 hours. And so then you have to remedicate. So you're doing this, you're constantly chasing your symptoms. Where with a tincture, it might take 20 minutes for it to start working, but you may get 5 to 8 hours of action from that dose if you don't hold it in your mouth too long. If you hold it in your mouth too long, then it's almost just like inhalation. It's only going to last 2 or 3 hours. But if you hold it enough just to get some absorption, and then swallow it, and you get that delayed onset. Then you get a delivery method that might only need 1, 2, maybe 3 doses per day. So I like that. Also,
What about, oh, I'm sorry, quick, just to interrupt you, apologize. But so going through the metabolizing the THC in the liver, and then there's a conversion to double hydroxy THC that has higher psychotropic effects.
well,
Yeah.
yeah, that's true. But most of my patients, when they're using THC by itself, they're usually using it at bedtime for
Oh.
sleep.
Mm-hmm.
Some will use it during the day. Those patients are usually using it for pain. And that 11-hydroxy THC actually has better pain relieving benefits than the Delta 9.
Mm-hmm.
So after using cannabis or THC over time, that impairing effect tends to get less prominent over time as the system gets used to it. But they can still get better pain relief from that from the THC, from that 11-hydroxy THC. But the
No, I'm sorry. I apologize. Go ahead. So with your geriatric population and the neurologic disorder, so again, I think of Alzheimer's, Parkinson's disease. Where do you believe, or what are you seeing in the research that you're looking for, that where cannabis there's most exciting opportunities to treat the symptoms associated with these devastating neurologic disorders?
Well, again, I don't see a lot of Alzheimer's, but certainly the science says that the THC interferes with the formation of the amyloid plaques. It doesn't, I don't think, do too much for the tangles. I'm not sure of the research in that in that aspect of the pathophysiology. But there have been a few small studies, a couple of Israeli studies looking at THC use in Alzheimer's patients. And certainly if you don't give them too much, a low dose of THC is anxiolytic, so it reduces their anxiety. It helps them relax a little bit. It stimulates their appetite. Sometimes they don't want to eat. And it certainly can help with sleep because oftentimes Alzheimer's patients, their circadian rhythm is way off, and they're up at night and they're a little bit more confused and agitated. With the sundowning, so the THC can help with that. But it's all about dosing. Small doses of THC can be quite therapeutic and avoid the adverse effects of increased anxiety or paranoia or confusion or poor coordination and reaction time and all of those adverse effects. Also, if you give THC with a little bit of CBD, and that's what I generally do with the tinctures, that CBD is going to mitigate that impairing effect from the THC, particularly the 11-hydroxy THC. But you can also use the CBD with Alzheimer's patients and avoid and avoid some of those adverse effects. But I think it's all about dosing. The Parkinson's patients, though, in my clinical experience, tend to do better with THC. And that's one of the few times when I do recommend inhalation. The reason being is that it's going to get in quickly and it's not going to hang around that long. So the Parkinson's patient, especially the men, they can take a few puffs, get their tremor under control, and they can feed themselves, they can shave. All of these little things that are important to people that are sort of demoralizing when you can't do it. And that's one of several times when I really do think inhalation is quite appropriate, and I actually recommend it. And then if they want to, then they can kind of use the benefit of the THC calming that tremor when it's needed. So before meals, before shaving, other activities that they have hobbies or things that require a little calmness of the hand. Then they can use the THC THC. But again, it's about dosing. It's about knowing how much to use and not using too much.
And that start low, go slow.
Always.
Critically important. So speaking to jumping forward a bit, is that with education and one of the things that I focus on is the void. And I see Izzy rising up. See my dog?
Oh, look at
the famous Izzy. He pops in every once in a while.
Hey, what do you want? Got any treats?
Welcome to COVID. Conducting business during COVID. Let's see, where were we? Is he distracting me? What were we talking about? The void of cannabis science education for physicians. So you and I were talking actually quite a bit about the need to be the need to be self-educated and where you got your education, and what have you seen come available in the to physicians since you started focusing your practice or including cannabis in your practice, and then where do you see the future of providing education for physicians?
Oh, it's going to improve, and it has improved since when I started. Really, the only research at universities were NIDA funded, and it was all about focusing on what the problem with cannabis was, and not what it could do, that was beneficial. Since I think it was 2016 when the University of Vermont School of Medicine offered a professional certification semester in cannabis science, and I leaped at that because prior to that it was the Society of Cannabis Clinicians that had an outstanding module, curriculum that I learned a lot from. But to be able to dive in a little bit deeper, I found it very helpful to doing the certifying semester with the University of Vermont. Since that time, of course, University of Maryland, they were offering, I think, some cannabis-related courses in some of the outlying campuses. I think Eastern Shore, I remember giving a virtual lecture there for students. But when the School of Pharmacy decided to move ahead with this curriculum, that was pretty exciting. I believe this is the first master's program in cannabis science and medicine, which leads me to not understand why the School of Medicine hasn't embraced this and why other medical schools have not started to incorporate, at the very least, the endocannabinoid system into their core curriculum, into the basic sciences.
I'm in that master's program. The first class, I refer to it as the guinea pig class. It's been exciting. It's been tremendous. But we often talk, or I have conversations with my members of my cohort about, why isn't the medical school offering anything on the ECS? And so then the Society of Cannabis Clinicians, and so you're chairing education.
Yes, I'm chair of the Committee on Education. This is an organization that was founded in 1999 by Todd McUleo, who was a California psychiatrist who very early on started seeing the benefits of cannabis in his practice. And at the time they established the SCC was to educate other physicians on the plant, on how it worked, and to establish a standard of care. Unfortunately, for a lot of patients, they go to a doctor, the doctor says, oh yeah, your condition is on the list. There you go, the dispensary will help.
Absolutely, yeah.
And that's not quality care. And patients who want to use cannabis as part of their regimen deserve quality medical care. And it's so we have established guidelines as to, you need a complete history. You need to understand what medications the patient is on. You have to understand the plant to be able to give some guidance. You don't recommend the same cannabinoid ratio or terpene profile for every single condition. And there's no way to understand how to treat a patient without knowing these things. And so they were the first in the world, really. They were first, certainly in the country, first in the world to establish these standards of care, practice guidelines, and to educate doctors on the system, the ECS, and how cannabis influences it.
Is it an international organization or is it U.S. focused?
Well, it's U.S., but we have international chapters. We have chapters in England. I think we have one in Australia. We're working with groups in France. I'm sure I'm leaving. Oh, South America. We have chapters in Colombia and Peru, and it's a great organization. We have a lot of the top-notch researchers and clinicians with years and at least practice years of experience in utilizing cannabis. And we have quarterly meetings, which a lot of the clinicians, we have clinicians from all over and from all different specialties attending the quarterly meetings, where we always have a speaker. It's a place where people can exchange clinical experience, which is unlike, I think, any other organization. And we're looking to launch our new modules. The last set of modules were developed in 2015. Now we have a brand new course with, we had 13 modules before. We now have, I think, 22 modules. And we have some of the best teachers, Bonnie Goldstein, Ethan Russo, Greg Gerdeman. I can't name them all, but we have some top-notch researchers and clinicians teaching these modules, and we cover everything: endocannabinoid system, the plant, all the clinical conditions, the pharmacokinetics. It's a good course.
And what's the URL for?
Well, we haven't launched it yet, but if the cannabis clinician, the EC's URL is cannabisclinicians.org, and it's a nonprofit. The membership is super reasonable, I think, and if you're a member, then you get discounts on the modules. So it's a real opportunity to get some quality education while we're waiting for the medical schools to catch up.
Yeah. Well, and so we'll end with, so you will again be with this roundtable conversation with your colleagues that you spoke of, Dr. Ethan Russo and Dr. Bonnie Goldstein. What is the topic of conversation that you're most looking forward to having?
Autism.
Autism.
Autism is that's where I focus. I'm a pediatrician by training. I took care of a lot of patients, evaluated a lot of patients with autism. I'm a mother of a grown child on the spectrum. I see a lot of autism, and it's so prevalent in this country, 1 in 59 children. So it's a really important condition to understand and to try to get some treatment for it, because there really is no FDA approved treatment for the core conditions of autism. And if we can get up under what's causing these debilitating symptoms, I think
that was actually the last module that I had in my master's cannabis science. Finished that up, was on autism. So I would have had a jump ahead on my classmates had I had the webinar a month ago. But in any event, I want to thank you for your time. Izzy is actually growling and letting me know it's time to wrap it up.
Time is up.
Time is up. So thank you so much for the generosity of your time. And We will see you on January 7th at 3 o'clock East Coast time, and you can purchase your ticket on Eventbrite. And thank you so much, Izzy, for joining us. Here he is, full view almost.
Well, thank you for inviting me. This is great. And I look forward to seeing you on the 7th.
Thank you. Bye-bye.
Bye-bye.